Hi, Tito. How are
Hi,
you?
Rodrigo. How are you?
I'm doing well. I'm almost in my hospital, so I'll be driving the first 5 minutes, but Rory will take the lead here, so we are good.
Okay, sounds good.
Thank you very much for the opportunity to present this work. We are very proud about that project. So yeah, thank you.
Great. Okay, we will be starting in 1.5 minutes. I'll let you know. Would you like to present something,
Yeah,
Rory? Okay.
I made some slides. Yeah, that I can
Okay.
share.
Can you share your?
Oh, no, it says only meeting organizers can share.
Okay. Let me help you with that. Okay, there you go.
Yep, we should be set. Okay. Awesome. Can you see my screen?
Yeah.
Perfect.
Hey, Tito. Just to confirm, to this
Uh-huh.
journal club, you invite residents and staff, right?
Right. Exactly.
Okay. Okay.
Okay, so we are ready to begin. So it's my great pleasure to present Dr. Rory Mother and Rodrigo Gutierrez. They're one of the lead authors of this study. They will be presenting today in our journal club. So it's a great pleasure to have you here, Rory, and thank you for the effort and presenting this study for us. So go ahead. Thank you.
No, of course. Thank you so much, everyone. So I'm going to talk a little bit about this paper that Rodrigo and I have been working on. Also give me some context from some similar papers that we've been just kind of using. I made a bunch of slides. Hopefully this helps in describing a little bit of the methods. I really did try to create some slides also on explaining how we actually built our little bit complicated statistical models. And so if anyone has any questions throughout any part of this talk, feel free to unmute, send me a question. I don't know if you can raise hand on Teams. I don't use Teams as often, but feel free to stop me at any point. Happy to answer questions. So a little bit about myself. Unfortunately, I'm not a doctor just yet. I'm still doing my MD, PhD at Harvard and MIT. I went to WashU for undergrad. I'm currently doing my PhD in biomedical engineering with Patrick. So I'm also working a little bit at Stanford University with him. But my other PI at Mass General Hospital's Edward Bittner. And so Patrick and I have been working with Ed on a lot of these different projects using, large scale epic data to try and predict outcomes or like emulate clinical trials to see how different outcomes influence postoperative opioid use, postoperative pain, things like that. So I'll just talk a little bit about motivation. So in the United States, at least, the opioid crisis, obviously, for people who may not know, is obviously one of the biggest kind of problems here in the United States. And so over the past, maybe around 10, 20 years, we've had around almost 1 million deaths due to opioid overdose. And with the past few years, it's kind of climbed to over 100,000 deaths. And so some numbers that really helped me understand how big this problem is in the United States, that all the deaths due to gun violence, due to car crashes, due to suicide, homicide, all are less combined total than the amount of deaths caused by opioids. And so this really made me want to think about how can we utilize surgery as an intervention model to understand how does that contribute to opioid exposure. And so at least in the United States, we know that most patients come out from surgery with an opioid prescription, and that upwards of a quarter of those patients continue to long-term use. And so this really started this whole set of projects looking at how can we look at using statistical models on large-scale retrospective data to look at surgery as a potential exposure that's causing these deaths. And so for a long time, people all kept asking, why do we even care about opioids? What are some of the stats and things that have shown that this is a necessary exposure to look at? And so I'll walk you through some just background information that, the Perrin lab really used to incite a lot of this research. And so we know for surgery, everyone anesthesiologist here, for surgery it causes acute pain. And we know that in the United States, 3/4 of patients use opioids. We know up to a quarter of those patients have persistent use, and then that can lead to cycle of withdrawal. And then we know that this is a DSM-5 criteria for the diagnosis of opioid use disorder. We also know from after surgery, around almost 20% of patients can have chronic pain after post-op chronic pain, and that upwards of 12% of those patients lead to opioid use disorder. And so you can see that really a lot of this surgery can really lead to all these downstream long-term effects of opioid use long-term. And so one big paper that Rodrigo really helped lead, and that was published in JAMA Surgery, a really pinnacle paper in our lab, was looking at the amount of opioids you receive during surgery. Does that even matter at all? And so we saw that if you increase the amount of opioids given during a surgery, you can reduce max pain after surgery. You can reduce in-hospital opioid use by 40%. You can reduce new persistent opioid use by 12%, reduce chronic pain incidence by 30%, which really highlights how looking at what's happening during a surgery really does matter and understanding its effects downstream. And so I think a big takeaway from this paper was that there's a large importance potentially of blocking nociception during surgery, that it's important to ensure that the patient, while going through the acute pain during the operation, that we should still be blocking the nociception from getting to the brain to prevent it from overreacting to those pain signals when the person is awake, to prevent long-term opioid outcomes. So that kind of like spurred this other side question. Okay, well, if your goal is to block nociception during surgery, why not just numb whole limbs? Which is kind of, the goal of regional anesthesia. So I don't need to explain to this group probably in detail what regional anesthesia is, but just really basically regional anesthesia, such as peripheral nerve blocks, looked at the study, is just used to totally block nociceptive signal transmission from regions of the body. And so you can imagine, of course, like for orthopedic surgeries or GI surgeries where you're only working in certain parts of the body, that it's helpful that if you could just block all the nociception from that section from going to the brain, you could potentially lead to less opioid use and less side effects due to anesthesia. And so there have been plenty of papers who have already showcased pretty robust results that regional blocks can decrease immediate post-op pain because, of course, you're numbing whole sections of the body, and you also can decrease length of stay, decrease PONV, sedation, constipation, itchiness, delirium, all because of the decreased opioid exposure. So that's all great. So this has really been pushed as a potential way to decrease opioid exposure. But a big question that we still really haven't fully answered is, do you actually decrease opioid consumption? So there's been many studies that have looked at this, and the problem with them is that they're all really pretty small sample size in the scale of 100 or so patients. And they all almost have conflicting results. So a lot of them don't necessarily do as robust a statistical analysis. Some of them say they have higher amounts of opioid use later, some of them have lower, some of them only look at specific surgeries. And so we wanted to try and see, could we answer this question more thoroughly for more operations at an entire institution, and also do a more robust statistical analysis to account for all the different sources of confounding or different messing up of variables and such. And so the question that we asked at this point was, why orthopedic surgery? Of course, orthopedic surgery makes sense because of the fact that they use a lot of regional anesthesia. And in the United States, it's also a really big increase globally, actually, with the expected increase of cases. So the expected increase across the world is around 50% for NIP and HE as people age. But I think the biggest thing here is that we're looking up not just our hospital, but across the United States, the actual utilization of peripheral nerve blocks varies a lot. And so on the right is a paper by Memsoides in Pain in 2016. And they basically looked at health insurance claims for hospitals all across the United States, over 3,000 hospitals, and looked at whether or not peripheral nerve blocks were used in hip and knee arthroplasties. And you can see the blue represents proportion of patients who received this block. And you can see that most actual centers in their study didn't give any blocks to anyone. And there's a few patients, few hospitals that towards the end that every person gets a block. And so we basically saw that there's such a high variation in its use that it gives you the opportunity to ask, okay, if that's kind of being used at random in theory across a large population, depending on provider, depending on hospital, could this be an opportunity to look at this question in a stats model to see whether or not that random use, quote unquote random use, leads to differences in outcomes for patients. So after seeing all this, we decided to have two just basic main objectives. So the first question we wanted to ask was, do peripheral nerve blocks lead to decreased post-op pain and opioid consumption? And we look at that both in the PACU and throughout the hospital stay. And then long-term, do peripheral nerve blocks lead to decreased chronic pain diagnoses and opioid prescriptions long-term? The reason, side note, that we only look at single-shot peripheral nerve blocks in the paper was just because there was no clear way to be able to measure, for example, a continuous catheter, the length of time that catheter was placed, how much medicine was placed through the catheter. It wasn't as clear through the med records, and so we decided to really hone in on the specific single-shot peripheral nerve block population since it was a little bit easier to identify on the charts. So what does this data look like? Basically, we were able to pull 4 years of data from Massachusetts General Hospital in Boston. We had 23,000 patients, orthopedic, and we only looked at patients who received fentanyl or hydromorphone during surgery. That's just because the other different opioids like remifentanil and such were a little bit, didn't have as much of a clear association to outcomes, and so we decided to hone into the opioids that we definitely knew for sure we knew how to model. Patients who didn't go to the ICU, no PCA obviously as well. And then for the exposure of a peripheral nerve block, we took that from the anesthetic record. And then what we did is we actually took the medication record from each surgery and used that to confirm administration of a single peripheral nerve block injection. And then for our outcomes, we looked at the maximum pain score, whether it be in the post-anesthesia care unit, up to 24 hours after surgery, and then throughout the entire hospital encounter. And we also looked at the amount of opioids they utilized, measured in morphine milligram equivalents in the same time points. And then we also looked at some general outcomes. So looked at PACU, hospital length of stay, chronic pain diagnoses, opioid prescriptions. There's also some post-anesthesia complications like PONV and time and sedation and things like that we also looked at as well. So I'm going to start going through the methods. It's a little more complicated. Hopefully I provide some slides that will walk these through a little bit more in detail. But we knew that, of course, there's a billion and one things that could potentially influence how much opioids or how much pain a patient has after surgery. And so we really took the time to go into Epic and really pull out every single thing we could imagine ever that would influence this outcome to try and really clarify specifically how does regional anesthesia or peripheral nerve block affect outcomes and try to find that clean association. So we have a ton of variables, and so we kind of bucket it into 3 different categories depending on when in time they happen in relevance to the exposure. So our exposure is peripheral nerve block that occurs, before surgery or right before the surgery starts. And so we care about things that happen before that happen at the same time as that, and then happen after that. So you can I'm not going to go through this all in detail. These are way more obviously categories, and I'm happy to talk through a little bit more specific questions if people have them. But on the left, you can see we have before surgery, like demographics, every patient's past medical and surgical history represented as billing codes. We have all the medications they received before surgery. And then during surgery, we have everything like the type of surgery, what specialty it's in, who is the doctor doing it, both anesthesiologist and surgeon. We have things like vital sign measures like time in bradycardia, time in low blood pressure, things like that. We give the anesthetic regimens, the actual dosing, as well as the type of medication used for anesthesia, and then any other intra medication use. So we also, for example, account for dexamethasone use. We know that is important for block length, and so we incorporated that as well. And then post-op outcomes I mentioned earlier, same outcomes I mentioned before. So in terms of the actual method, so in this case, we care about the exposure of peripheral nerve block, and we have these outcomes. And you could probably, run a standard linear model and be able to say, what is the association between these two things? But the problem with that, if you just build a linear model with no other accounting for any other variables, the problem is that you're not looking at a causal framework. I cannot say that the peripheral nerve block causes these changes. I can only say that they are connected somehow. So for example, there might be things like if they receive dexamethasone as a good example, where that in itself could cause a difference in the length of the block and really influence outcomes. And so if I don't account for that, or other things like age, or other things like the actual surgery itself, that would potentially not allow me to say that this block causes this effect. And we were really wanting to know how much does the block itself cause changes in outcomes. And so instead, our framework looks at, okay, so we have our exposure. We want to know its influence in outcomes, but we also want to account for all the preoperative junk before, so all the past medical history, past surgical history, other medications they've taken, and try to eliminate that influence. And so we use a method called inverse probability weighting, which I'll explain in a second. And then we also know there are things that happen during the surgery, like dexamethasone use or anesthetic regimen, things like that. And so in our models, we also adjust for these other confounders that occur concurrently with surgery. And so these two methods, the inverse probability weighting and the adjustments, I'll talk about in a little bit more detail. And so first, we'll talk about this one on the left. So I give a really, really basic example. Say you have, this is my population I pull from the health record. On the top are the group of people who have a peripheral nerve block, and the bottom are the people who did not. And we can kind of see that I mentioned the blue is male and the pink is female. And we can already see that in the bottom, no peripheral nerve block group, that there's a majority of people who are male. And so if I were to model this and see how does the nerve block affect outcomes, the problem that I have is that there are more men in my no peripheral nerve block group. So for me to make conclusions about the effects of peripheral nerve block, I'd have to be okay with the fact that there's more men and that might, mess up my results. And so the way that propensity score reweighting works is that, imagine if we just had this one variable, what we could do is, you don't want to remove patients because you don't want to decrease your sample size, and you can't add any more patients. And so what you can do instead is that you can reweight, you can emphasize or de-emphasize specific data points to try and rebalance the presence of the different variables. So in this case, for example, in the bottom group, we could increase the importance of the female data points because they're not as common, and we could decrease the emphasis of male data points since we have so many of those. And so by doing that, on the right side, you can imagine that if I were to calculate the influence of sex on whether or not you received a peripheral nerve block, the answer would be no. There would be no influence because the balance of male and female across the two groups after balancing is equal. And so propensity score remodeling reweighting works is that you take all the pre-op variables that you care about, and then you calculate a propensity score, which basically is saying, can you take all these variables to predict whether or not they received a peripheral nerve block? And then what you do is then try to balance your data based on that score. And so you can use linear modeling, machine learning, any fancy model that you want to try and take all of these different variables to predict this single value propensity score. And then what you do basically is then, so imagine you had your raw data that's imbalanced in terms of propensity score. You can weight the data based on that score, and that way you create a cohort between your treated and your control in which all of these different variables are basically balanced between the two. So that way you can say, okay, height, weight, sex, all past medical history, all baseline meds, none of that influences the probability that you receive a peripheral nerve block. So none of those variables no longer matter in terms of understanding the effect of nerve blocks to outcomes. So that's a really basic overview. I'll stop really quick if anyone has any questions about how that method works at all.
I think we've seen some of these kind of studies. We have worked with some of these methods, so we are pretty familiar with it, I think.
Okay, awesome. Sounds good. So we did all these, we looked at these variables on the left side here and tried to incorporate them. The one thing that was kind of giving us a problem were all the past medical and surgical history. And so for that, there's over 6,000 different codes that represent each individual patient's past medical surgical history. And so you can imagine that trying to incorporate 6,000 variables, regardless of how many data points you have, hundreds of thousands, like tens of thousands, whatever, it's just too many to account for because then you start to overfit your data. And so one other method that we utilized in this, in most of these papers, is that we used machine learning to try and condense the set of variables to be more reasonable in general. And so I'm talking about this because I think it's kind of interesting. I think it's cool. Obviously, I'm at MIT, so machine learning is always, fun. So we use machine learning to try and do this question. So we actually utilize a very similar method as ChatGPT or any of those different chatbots to try and condense the set of all diagnosis codes into a smaller set that we can account for in our analysis. And so really quickly, ChatGPT, the way that it broadly works is that you give it a sentence. So for example, your cat is a lovely cat. And then what it does is that it calculates what is the relation of each word to each other in the sentence. And then you can utilize the relation of each word to other words in the sentence to extract meaning. And so you can also measure that meaning. So in this case, you can see like the word making is connected to all these different words with different strengths. And so you can say that, making and more might be the ones that you put together because they are more highly related. You can imagine you can do the same thing for disease. So imagine if I had this patient who had all these different diagnosis codes, and I tried to calculate on the left here, how do all of those codes relate to each other? And then try to calculate the score of them, how connected they are. Because for example, like cystic fibrosis, that could lead to a high rate of diabetes because of the pathophysiology of that disease. And so rather than having two codes to represent both, why not just have one variable that represents both at the same time? And so instead of looking at individual diagnoses, could we look at syndromes of disease and try to adjust for syndromes of disease is kind of the way I think of it. And so you can do the same thing here. You can put one code here and you can look at the connection to the other ones and then try to condense the number of codes together. And so basically you go from 6,000 different procedure and diagnosis codes to 256 variables of just zeros and ones. And so you can see that going from 6,000 to 256 is much smaller, much easier to account for, and really allows us to account for the entire history of past medical history, past surgical history in each patient to ensure that our analysis is correct. So that's an overview of just broadly what's happening here in the red. And so what's happening on the red is we take all these variables, we condense them down, put them into this propensity score, rebalance our data. And then in the blue here, so anything that occurs during surgery, we just interlinear model, include variables to account for things that occur at the same time as the exposure. And so I list those out here. But that's kind of just a broad overview of the statistical modeling.
Rory?
Yes.
Hi, I'm Juan Pedemonte. Just one question. Why 256 features or variables? Why not 300 or 100? How did you decide the number?
Yeah, so machine learning nerds love to do things in factors of 2. So you go like 2 to whatever power is 256. That's kind of like part of the reason. But the actual reason is just that you basically have to trial and error the number of variables you need to actually well represent your data. So when we were doing this part and trying to see how many, we need to basically just guess and check how many variables we needed to represent this 6,000 well. So that was kind of the reason, just kind of guessing and checking until we found it.
Great, thanks.
Yep. Awesome. Any other questions? No? Okay, great. So to summarize, we basically use linear models to predict outcomes. The only other thing that I'll mention later down the road is that we looked at a counterfactual estimate. So that's just a fancy word to say that we took our linear models and we basically asked if every patient received a peripheral nerve block versus no one received a peripheral nerve block and saw what was the difference in the outcome for that estimate. And the reason why we did that was mostly to kind of illustrate what the effects could be broadly for a clinical site if they were to do that. And that might seem far-fetched, but I showed earlier that in the United States, there are like majority of hospitals who don't receive any peripheral nerve block, and there's some that everyone receives one. So we thought that it was an interesting result to kind of contextualize the effects of these models. And we use Bootstrap to look at confidence intervals. Okay, so I'm going to go through the results. I think most of this is just the slides of the figures from the paper, and so happy to talk about this in more detail. But really quickly, so we had around 23,000 patients. The average age is around 54. With the spread here, you can see around just below half is female. The most common surgeries are probably what we expect. A lot of arthroscopies for knee and shoulder. We have total hip replacement, total knee replacement here listed as well. And then we around 40% of patients in this population who received a peripheral nerve block, you can kind of see here the different spread of the different medications utilized for these blocks. So one important consideration for this is that we didn't actually account for the type of medication used in the block. The biggest reason why is because we couldn't account for the dosing because the way that the medication is listed in the record. So we just kind of have a singular variable at saying whether or not they received a peripheral nerve block at all, and that's what our exposure is. And then here are just the distributions of the outcomes. And so you can see that for both PACU max pain and PACU opioid usage, that most patients actually receive 0. And so I think we've kind of seen at Mass General Hospital that within this time span, a lot of people don't actually receive a ton of opioids. And so, but you can see that there is a broad spread in the pain scores throughout, and then also in the amount of opioid use, which kind of peters out towards the high end. Okay, so this is the big table. I'm going to split this up a little bit to kind of walk it through piece by piece. But basically what this is a forest plot, just looking at what is the different effects of peripheral nerve block on all these set of outcomes. This dashed line represents the null, which means that there's no difference. On the left means that the peripheral nerve block improved that outcome, and on the right, it means that it made it worse, basically. So let's look at pain score first. So all of these ones that are for pain and for opioid use are ordered between for PACU, 24 hours after surgery, and in hospital use. And so we can see that already that basically peripheral nerve blocks decrease pain in PACU in the immediate post-op period, which we expect. That's what other people have reported. But we do see that peripheral nerve blocks increase max pain towards the end of the hospital stay. Looking at the opioid side, so the opioid outcome is split into 2 parts. The first one, the binomial piece, asks, did they receive opioids at all? Like 0, 1. And so you can see here that because most people receive no opioids, that's the reason why we did it this way. But you can see here that in the PACU, that the probability of you receiving any opioids at all is lower in PACU if you received a nerve block. And then after surgery, upwards, even at discharge, that throughout the hospital stay, the chances of you receiving any opioids at all increases. And then if you were to remove all the zeros and look at the patients that did receive opioids, we can see that this one is looking at, okay, if you did receive opioids, how much did you actually receive? And so you can see here that you don't receive necessarily more opioids in PACU, but you do receive more in the total hospital stay. And so this result mirrors the pain result, which is that in PACU, things are broadly lower, and then in the hospital stay, things increase. Looking at some of the other long-term chronic pain and opioid outcomes, we can see that chronic pain diagnosis decrease as well at 1 year after surgery. And then all of the post-op opioid prescriptions, whether or not they have a prescription active after surgery, is 30 days potentially borderline significant, but in all reality, probably not that different for all these different outcomes. And there's no difference in persistence of use. And then last one, looking at the different anesthesia complications, we can see that all of them are broadly the same. Hospital length of stay is maybe slightly decreased. The biggest one here is that the number of people who are readmitted 30 days after surgery does drastically decrease as well. This is a total table of the counterfactual, so it's looking at the comparison of outcomes if everyone received it versus no one received a peripheral nerve block. Lots of numbers on this page, but I'll just focus in on these 3 here. So these are the opioid usage outcomes and you can in the hospital. And you can see here that what this is saying on the in-hospital MME is that if you were to receive a peripheral nerve block, you would have 0.68 less MMEs in the PACU, but you would have 64.3 more in the hospital encounter. And this is a 22.7% increase if you were as compared to baseline. And so, yeah, very showcasing just a really drastic increase, a notable increase in the in-hospital total usage of opioids as compared to potentially the benefit you receive in PACU. So I'll talk a little bit about the discussion here. So also to contextualize that outcome I just showed, that counterfactual outcome. So if we were to take this FME values and translate them to 5 milligram tablets, basically you can see that for our population just within one hospital over 1 year, that you would give around 2,500 less 5 milligram oxycodone tablets in the PACU, but you would give almost 250,000 more throughout the hospital stay if you were to give everyone receive a peripheral nerve block. And so it really showcases that some of these things might seem small on the patient-to-patient case, but if you were to extrapolate this to one single hospital, you can see how many more opioids that you get to save if you were to think about your peripheral nerve block protocol more carefully. And I think the biggest thing we saw was that this is really recapitulating what people already know happens with peripheral nerve blocks, which is rebound pain. So we know the block only happens temporarily. And oftentimes, at least in the United States and also Massachusetts General Hospital, our home institution, we know that the regional team doesn't stick with the patient the entire hospital stay. They kind of do the block, they kind of check in a little bit after the surgery, and then they'd often just leave it to the surgery team or whatever inpatient team is taking care of them. And at least for our groups, when checking what is the post-operative opioid protocol for patients with peripheral nerve block, there's no standardization. And so there are some patients who might get started on an opioid regimen to ensure that their pain is well managed after the block wears off. But I think in often cases, they leave it up to the primary team. And so you're leaving the opioid care to a team that may not have the expertise to handle pain for patients who receive a nerve block in general in the United States. And so we think that's the reason why we see an increase of pain after peripheral nerve block wears off. And we also see like a really drastic increase in the amount of opioids they use. We did see that there was a pretty drastic decrease in the amount of chronic pain diagnoses 1 year after surgery. We don't exactly know the exact reason why this occurs, but some hypothesis we had was that that this kind of emphasizes the importance of blocking pain signals in the acute timeline during surgery and maybe the acute timeline right after surgery. And so our thought is that maybe by blocking the pain signals in this acute process during surgery, that you're preventing majority of the detrimental pain signals from occurring. And so even though you take more opioids in the short term during the hospital stay, that a year down the road you're actually helping your brain, preventing it from developing central sensitization and preventing chronic pain long down the road. Okay. That's all of my slides. Happy to talk through things in general. Just quickly want to say thanks to the other first author, who is she's one of our actual research assistants who took on this project as part of her last year in the lab, and then everyone else in the Pern lab as well. But happy to talk through any questions in case people were curious about anything.
Rory, that was a great review of your study, and thank you for being here with us. So we will open here the debate.
That sounds good. And Rodrigo, feel free to chime in if I missed anything in general.
Yeah, I would like to, Tito, can I talk?
Sure, go ahead.
Okay. Yeah, I just want to highlight two things about this study, and thank you, Rory, for your great presentation. The first one is when I look at these results, I do think that with pain there is something that it's related to expectations, right? And when you are undergoing when you have a surgery, let's say a knee replacement, and then you wake up from your anesthesia and you're in the PACU as a patient, I'm talking, and then you have zero pain. It's like maybe your expectation is like, okay, I'm done. I'm already went through the surgery. I won't have pain after all, right? Mm-hmm. And then you go to bed and you have a nice night, and then the next morning you wake up on pain. And then how do you value that pain? Is probably influenced by the expectation that, wait, yesterday when I had the surgery, I didn't have pain, and now I'm having pain. And then I think that's something that might be influencing this rebound pain and how much. And then you score that pain, and then you will receive opioid in response to that, right? And as Rory said, there's no homogeneous regimes for analgesics, right? It's not depending on the regional block team. So that's one key thing that I think that it is important to consider in the interpretation of the results, expectations, which is super important for pain. And then the second one is the chronic pain result, the 12 months chronic pain result, which is, to me, the most important result in this paper, because the magnitude of the effect is big. it's way far from the confident interval boundary. So we are pretty confident about that signal that we are observing in this data set. And although we don't know the mechanism, it's reassuring that if you do block nociception during surgery, you will have better outcomes.
Yeah, thanks, Rodrigo. I totally agree. I think that all makes sense as well.
Rory?
Yes.
Juan again here. A big question of this type of studies, although there are huge, like the numbers are huge, 23,000 patients for a prospective trial is impossible, basically, or really, really expensive, right?
Yeah.
Is the probability that you may have like it's called like a selection bias, no? So at least for me as an anesthesiologist, I usually use a peripheral nerve block when I know that a surgery is going to be very painful, right? So I understand that you also put into the propensity score the type of surgery, right? Because I read the characteristic, but the type of surgery. So I can assume that there's the same number of I don't know, knee arthroplasties in both sides of the comparison, right?
Yeah. Yeah. So I think what you're saying is true. We're only looking at one site. We're also obviously a tertiary site, so a pretty high complication site. I will note that we do also receive, I think, some of our data from some of the other hospital sites across Boston. So it's not fully like, only Mass General Hospital. In terms of balancing for the type of surgery, yes, it does its best. As you can see, like we do have a very specific type of distribution. So we have mostly arthroscopes and not as many arthroplasties, just because we found that a lot of the actual replacements don't utilize different types of regional block, or don't use it at all, or only use regional blocks. So that was kind of didn't have enough variance for us to incorporate into our data analysis. And so, yes, I would probably tell you that I'd have to look to see every single surgery were balanced well, but our analysis does suggest that all of that is balanced across the two groups.
Great, thank you. And the other question, this is probably more for Rodrigo. Do you think your results would be different if you have used peripheral continuous blocks, like catheters?
I definitely think so. And just to expand Rory's answer, probably the type of surgery that were included in this study were like not the most painful one, because in those surgery, like knee replacement, most of the patients will receive a block, right? So you won't have the randomness to balance the groups. So we have middle, like a knee arthroscopy, right? It's painful, but it's not like a replacement. And therefore, single shot could be an option or could not be an option, and then you can compare. So for more painful surgeries, you can consider continuous blocks, and then probably the result will have been different. I would expect that.
Yeah, I was gonna say, now I'm remembering back to why we don't have as many of the different replacements, arthroplasties, is because a lot of them doing under spinal. They get a spinal anesthesia, and so that was a big problem. Is that some of them are just completely done that way and don't have as much with just blocks in general anesthesia. And then to the continuous piece, that's something we're actually curious about. I know we were talking about this paper with our colleagues at Stanford, and we actually learned that almost all of the most recent surgeries have been utilizing continuous catheters for their nerve blocks. And the nice thing is that that requires the regional team to round on their patients basically throughout the post-op period. And so I think that the head of regional anesthesia here at Stanford has been a little bit thinks that potentially the use of continuous blocks is more going to help with a little bit of these results. But I think the limitation of that we talked about was not every hospital can have a team that follows every patient if they do a continuous block on everyone. So Stanford's very well resourced. They have a ton of people that go around in addition to the primary team. But in general, there's a lot of health sites that will only use single shots, a little bit easier to do. And so I think that this probably still will be necessary consideration for nerve blocks for all hospitals across the US at least. Fernando, you have a question?
Yeah, thanks, Rory. Thanks, Rodrigo, for the presentation. It's a really interesting study, which I would say that goes in the same way as our current practice here in our hospital, using a lot of continuous catheters for most of the surgeries. We have the experience, as you said, that or acute pain service patients, and as Rodrigo said, that probably continuous catheters will help with the pain results. And actually, there are some older studies showing that if you increase the length of the continuous catheter infusion, you could decrease the pain that you're experiencing when the block wears off. So I think that the results are really compelling with the expectations that we have using these kind of techniques here in our hospital. I have two questions. One is related that you already said about the use of neuraxial blocks, because I mean, I think it's good to have a spinal block, and it could cover quite well the first hours. But maybe you could have the same problem even having the spinal block in terms of the rebound pain. So do you have any plan to go into the spinal block and the regional anesthesia as a neuraxial block as a possible a way to study this as well?
Yeah, so we looked into it. I think the problem that we had was at first with this specific analysis, we didn't feel like putting spinals and nerve blocks in the same category made sense, because they're just completely different in terms of the amount of spread of body covered and how long they last and such. So that's the reason why we didn't include it here. And the second reason was because the types of surgeries that receive spinals, like basically everyone received a spinal based on the anesthetic practice at the institution. And so it's been a little harder to look at that. And also comparing a spinal versus an epidural, there was like, how do you see that difference in the record? That was also really hard. So I think there's a question of whether or not we would look at all neuraxial in general as one question potentially for future studies. And I think that the nice thing is that we actually, on Med Twitter, got retweeted by one of the people who ran the Regain trial, and they looked at a multi-site clinical trial looking at spinal versus general anesthesia. So a little bit different, but in their 1,600 patient or so trial, they did see similar results as us, where patients had more opioid prescriptions long-term, a little bit more, I think more pain as well, long-term as well. So I think that overall, it seems as though based on that trial and our results, that there's kind of a singular thread that just temporary numbing of parts of the body may not help in the long term. But to answer, but yes, the plan is to try and look at that as a next step.
Thanks.
Yeah, of course. Rodrigo, you had something to say?
Yeah, it's a question for Fernando. For how long do you have the continuous catheter at the UC hospital in general?
Well, yeah, it depends, but mostly 60 hours is the length of the infusion for a 300 ml reservoir. But in some selected cases, we could change the pump and put another one. But I would say that 54, 60 is the average.
Okay, I see. So they are fully covered basically in the acute period.
Yeah. Well, that's the idea.
That's great. Yeah, that's great. And then you have a specific team to follow those patients. How do you follow that?
Well, actually, we do. We have the acute pain service in the hospital patient setting, but also we have the ambulatory setting, sending patients to home with the catheters, and a team is calling them by phone just to be sure that everything is all right.
Okay. Yeah, that's great. That's great.
Yeah, much nicer than what we do here, which is nothing. So. Any other questions from the group here? I'm hopeful that means that my presentation was super clear and we had no other explanations.
Yeah, probably. Well, thank you very much for your presence
course.
here and for presenting this study for us. We're
Of
very
course.
grateful for the effort.
No, of course. If anyone has any questions, you can feel free. I'll put my I can put my email in the chat. Ooh, well, people can email me. They can find my email on the article itself. And so if anyone has any questions, feel free to send me an email. I'll ask Rodrigo as well.
Okay, that would be great.
Thank you so much, guys.
Thank you very much, Rory.
Awesome. Thanks, everyone.
Thank
Alright.
you.
Bye, guys.
Thank you
meet you.
very much
Bye.
for the invitation.
Bye.
Bye bye.
Bye, Rodrigo.